What else ممكن يتعمل للعيان يعني هفكر في ايه؟ انا دلوقتي now I'm faced with a patient with hereditary dystrophy, and I'd like to do something for him. So patient with retinitis pigmentosa, what are the ocular complications that I may deal with to improve the vision of the patient?
هما يعني they are more prone من الكيسز اللي احنا شفناها they are more prone ان يجيلهم posterior subcapsular cataract.
Exactly.
بس يعني we were told برضو ان cataract removal will not improve the vision that much يعني, and they will come back with severe capsular phimosis, and it happened يعني.
تمام.
ممكن macular edema أو macular cystoid macular edema.
Cystoid macular edema is more common with them, and some may advocate using carbonic anhydrase inhibitor drops, something like the Azopt or something like this. They think it may improve the cystoid macular edema. I personally don't have experience with that. Careful refraction in those patients may help a lot if there's a significant refractive error. Low vision aids with these patients may help a bit to help them to read better. Sometimes you don't have much options, but those are the things that you should think of. Okay.
طب دكتور اسلام, should we يعني ask more investigations زي ما بيتكتب في الكتب كده for such patients EOG و ERG و visual field, ولا خلاص it's a straightforward case?
I think those investigations are only useful if you are not sure about the diagnosis. The thing that may be useful is the genetic counseling. It's not available. It's very expensive, and it costs a lot. But this is the thing that I think it will make a difference with the patient. But other than that, it will not add much value to the patient if you do a visual field or an ERG or an EOG or whatever. I don't think it will make a difference. Okay.
معلش انا بقى عايز اسال سؤال دكتور اسلام. How do we comment on the fluorescein in this case?
انت لو قدامك الكيس دي هتبدا تعلق ازاي؟ I'll start by commenting on the color photograph, saying that here we have a pallor of the retina with or yellowish discoloration of the retina, bony spicules present all over the extramacular area. I'll say that there is some attenuation of the retinal arterioles. The retinal arterioles are not of the normal thickness. The disc appears normal to me. It doesn't have the classic waxy pallor appearance. By the way, what type of optic atrophy is present with cases of advanced retinitis pigmentosa?
Consecutive?
Exactly. It's called consecutive optic atrophy, and usually it is waxy pallor in appearance. Okay? In contrast to the pale color of the primary optic atrophy, for example. Okay? So I'll say in the color photograph, I have 1, 2, 3. Then move to the red free. The one next to that is the red free. This is before injecting the dye, I believe. Isn't it?
Yes.
Okay. I'll say again, I can see lots of dark areas corresponding to the bony spicules hyperpigmentation seen in the color photograph. And then in the fluorescein angiogram, I'll say that there is blood fluorescence corresponding to the areas of the peripheral hyperpigmentation. And in addition, there is an enlargement of the foveal avascular zone. It appears enlarged, which indicates that there is an element of ischemia here. Okay, so those are the two things that I would comment on. I may say that in the perifoveal area, in the macular area around the fovea, there's a bit of hyperfluorescence corresponding to the mild increased thickness and cystoid spaces around the foveal center in the OCT. Okay, so this is why I'll comment on that.
Okay.
Again, using hyperfluorescent, those are the terms that we use. Okay.
Okay.
Thank you, Dr.
دكتور
Saad.
اسلام
Thank you very much.
عندي سؤال بس يا دكتور اسلام.
طبعا.
هو دلوقتي الهايبر pigmentation هنا is reaching almost the center, right? يعني it's approaching on يعني on the macula. هي لسه ما وصلتش بس داخله على يعني already على المارجن. ده هنا يعني can we stop us progression with any means؟ يعني في new means مثلا، في ناس مبعوثة عشان ال stem cell transplantation والحاجات دي، هل دي فعلا اثبتت حاجه بره او جوه مصر؟ يعني ما اعرفش طبعا موجوده
in my modest experience, no, there's nothing that you can do to stop it.
اوكي، شكرا.
Anyone else would like to present?
I will try to share my screen.
Anyone else having questions? By the way, is there any rule for the steroid injection in diabetic retinopathy? Intravitreal steroid injections?
I think just in refractory cases.
We do it very, very, very rarely. So it's a dying thing, okay? In the past, we used to do lots of injection. When I was a resident, lots of injection of triamcinolone in the intravitreal injection of triamcinolone for diabetic macular edema. Now I have not done that for probably, say, 10 years, something like this. Okay, so, and you should do that only in pseudophakic patients and in patients who you know that they are not steroid responders. So in some patients, you may put them on prednisolone drops or dexamethasone drops for 3-4 weeks to see if they are steroid responders or not before doing the injection. There's something wise that you can do. And to be frank, I don't find a clear indication or a reason to give those injections, except in cases with refractile, what we call refractory diabetic macular edema, and we may, you know, we are not very encouraged to do to push the patient to have the steroid injections. Okay.
Okay, Dr. Steph.
Okay, Dr. Walid, if you'd like to, yeah.
هو السكرين واضحة عندكم؟
Yes, it's very evident. Yeah, please go on.
It's a 78 years old male presenting with gradual decrease of vision, especially noticed in the last month. OU, past medical history, non-diabetic, non-hypertensive, ocular history, cataract surgery, OD 15 years ago. Examination, visual acuity is hand motion in the right eye and 360 in the left eye. He is pseudophakic in the right eye with nuclear sclerosis of second degree in the left eye. Fundus examination reveals a grayish lesion in the fovea with elevated retina suspected to be CMV. This is a colored fundus photograph of the left eye. We can see there is a grayish lesion in the center of the fovea or center of the macula encroaching on the fovea. And I think the lower one is the red-free color with also a grayish lesion, darkish in the center, and there is like more not fluorescent, but I don't know how to describe, whitish areas around it, surrounding it.
Okay, one small comment here, so if you allow me to interrupt. This is not, you should know that this machine, this is the Spectralis machine. The Spectralis machine doesn't give a true color photograph. It's what we can, because it doesn't use visible light, it uses infrared light. So this is not a true color photograph. You should notice that in all the patients for whom the scans are taken with the Spectralis. Okay.
Okay.
Okay, Dr. Walid, go on, please.
We ordered fluorescein angiography for the patient. We can see in the early phases there is no hyperfluorescence center of the macula, but later on there is increase in the hyperfluorescence and with areas of hypofluorescence in the center. I don't know if you want to add something.
I'm just looking at the time interval. and I'm looking at the edges when I'm evaluating a fluorescein. What I'm looking at is the edges of the hyperfluorescence. Here, to be frank, I cannot see much leakage. It's more the lesion is very well circumscribed. Of course, the OCT will add a lot of information, but here I can say that it's well circumscribed, but it is becoming more and more intense. Within the area of the lesion, there are some leaking point, but they are not at the edges, to be frank. And
Okay, is this
Dr. Sam, can we call
or not?
this late staining?
Sorry, I can't hear that.
Can we call this late staining?
معلش دكتور خضر قول تاني علي صوتك شوية.
بقول لحضرتك can we call this late staining of a macular lesion?
I can say yes. I can say yes. Yes. It's not very late actually, because it started to appear from the photo on the upper right hand side, 1 minute 45 seconds. But I think there is I'll be interested to see the OCT and correlate the OCT with the fluorescein.
Okay, but to be honest, I want to ask if this is the stippled appearance or not in the fluorescein and around the fovea in the center.
If it's what? Sorry.
Stippling, the stippling appearance, we can sometimes see stippling in the center.
I'll say probably yes.
Okay.
Of course, you can see. Okay.
Okay. Sorry.
I was saying that there are lots of drusen or staining temporal to the big lesion. There are many hyperfluorescent drusen. They are not leaking. They are just taking the stain, and or even some of them are window defects because they become less evident in the later in the angiogram. So in the image on the right hand side, they become less evident than the one on the left hand side. So this probably is a window defect. Okay. So if we'll move to the
decreased, right? The intensity decreased.
I'll say yes. Some of them decreased. I'll say that if I'm comparing the right and the left, I'll say that the intensity, especially on the ones on the extreme temporal side, they are becoming less intense. Do you agree with me or not?
Yes, I'm agreeing.
Okay.
معلش يا دكتور اسلام دي هتفيدنا في ايه لو هي decreased او increased؟
هتفيدنا في ايه لو هي ما هي احنا عايزين نعرف هل هي staining، يعني هل الدروزن ده كبير وهو واخد ستين، ده في الغالب هتلاقيه ثابت، السايز is constant but the intensity becomes more and more. Sometimes the drusen is not that big and it's just causing some erosion of the overlying retinal pigment epithelium, and it will fade, so it will start hyperfluorescent and then decreases in the late angiogram. It doesn't have much clinical significance. Both of them are considered inactive and they don't require treatment, but it's just, just to know what we are talking about and just to differentiate whether this is a staining or a leakage or whatever. تمام دكتور مايكل؟
شكرا.
تحت أمرك. So if we'll move to the OCT.
Yes, this is the OCT ordered for the left eye. The vitreomacular interface is intact. The foveal contour is not distorted a little bit, but I think in the deeper layers there is increased. I don't know what's the exact description, but there is elevation of the layers here, but there is no leakage or cysts around it in the inner.
So I'll say that there is atrophy of the outer retinal layers, the outer retinal layers of the photoreceptor layer, the outer plexiform layer, they are atrophic, and there is what we call a fusiform thickening of the retinal pigment epithelium. So it's a large area of irregular surface of the retinal pigment epithelium choriocapillaris complex. Okay. And what do you think that can cause this appearance? What's the cause of that?
Is scarred CMV or what?
Mostly this is a CMV scar. So even before looking at the OCT, a careful look at the fluorescein, by a careful look, I could say that there is no leakage and it's mostly staining. So mostly this patient is not having an active CMV. And then the OCT confirmed that to me. So we can say that the fluorescein is just like the thing that we used in the old days before the OCT. We depended entirely on the fluorescein to say if the patient is having leakage. This would indicate that the lesion is active. If the patient is not having leakage, he is having a window defect or a staining, then mostly the patient is inactive. Of course, the OCT is adding lots of more information now, but it's important always to correlate both of them together. Okay?
Okay. Can we say the type of CMV that was here, for example, classic CMV, or we don't?
It's a bit difficult to say here because it's inactive right now. It could be as a classic or an occult CMV. I will go more with the occult CMV, but I'm not 100% sure. What makes me think about it was occult, the vision of this patient, if I recall correctly, it was 0.4 or something like this.
It was 360 with cataract in this eye.
360 with cataract. Okay. By the way, what's your advice about the cataract surgery in those patients? How would you counsel them?
I would counsel them if the cataract is dense enough, that the vision may improve a little bit, but it's not gonna improve 100%. And I don't know if there is the regaining of activity in a scarred CMV after cataract surgery or not. I'm not sure.
Okay, so 2 points here. First of them, you should mention clearly to the patient that the central scotoma or the central metamorphopsia is not going to improve. We will try to improve the vision in the peripheral part of the field. This should be very clear to the patient, okay? Second thing, there is no correlation between the cataract surgery and the recurrence of activity of the CMV. There is no proven relation between them. So it should be very clear to the patient that if it will become active again, and by the way, this is not very common with such big scar, I don't think he or she will become active again. This is very unlikely. The cataract surgery is not responsible for that. This should be very clear before the start of the surgery. Okay?
Okay.
Okay, very interesting case.
So the interesting is the other eye. Sorry, Dr. Islam. The other eye has another CMV. This is the other eye, fluorescein, with hand motion vision and pseudophakic. Actually, if I'm going to describe this one, I think there is in the early phases there's central hypofluorescent area with staining with hyperfluorescent area above it, and on later phases there is hyperfluorescent areas around the fovea, levascular bone. But I am not seeing any leakage, or I think it's staining too, or there is a leakage. I don't know.
Okay, the only thing that I'm concerned about in this particular scan, can you see there is like a ring of hyperfluorescent in the fovea?
Yes.
Okay, let's say at probably 7 o'clock position, there is a spot of hyperfluorescent that increases gradually in size and in intensity. This is the only thing that I'd be concerned about in this patient. But other than that, all the borders seem very, very well defined to me. There's no, the ill-defined border of the leakage. I cannot see it in any part except at the point at the 6.5 or 7 o'clock position. If you would like to, can you see it? What the point that I'm talking about?
Yes, actually, this one.
Exactly, this one. Exactly. This is the one that I'm concerned about. Okay. So
دكتور اسلام
again,
دي ممكن نقول
with the
عليها
vision of
occult.
I'll say that mostly this is a CMV scar, but I'll be interested to see the OCT on that area to see if there is a bit of activity or not. And taking into consideration the vision of the patient, what's the vision of the patient in that eye, please, Dr. Walid?
Hand motion.
Hand motion. I'll say mostly he or she will not get benefit of doing injections. With the vision of hand motion, usually it's too advanced, okay?
Okay.
So even if I'll say, I need to be wise, sometimes you find a patient with a massive CMV, very poor vision, and still there is subretinal or intraretinal fluid. He or she will not get benefit of more injections. You have to have the courage to tell them, stop, don't have more injections. You need to stop. Okay?
Okay, when the vision is not promising, right?
When the vision is very, very poor and there is a massive scar with some activity, it will not make a big difference. But if the vision is still not too bad or the scar is not too big, you should keep on treating the patient because he or she may lose more of the central vision. You don't want that to happen. So let's have a look on the OCT of this eye, of the right eye of the patient. Okay.
Yes, the OCT.
Okay. So as I mentioned,
yeah,
there is again an ocal CMV still with some activity because there is still some subretinal fluid, but I doubt very much that the patient will get benefit of injections.
Dr. Islam, what explains the vision of hand motion if the periphery of the retina is normal?
Because the central vision with a patient with such big CMV, all the central vision is gone. And the patient is not seeing with the macula. He or she is just seeing with the peripheral retina. So I will not expect a vision better than probably hand motion or counting fingers 50 centimeters in the best condition. Because all the macular area is affected. If you can see here, the white color on the upper photo of the macula, the white color which indicates massive thickening, is taking almost all of the macular area. It's not a small CMV, it's a massive CMV here.
You mean these areas, Dr. Islam?
No. On the upper image, the false color code of the upper image.
Okay.
That area, it's huge and massive and including almost all of the macular area. So here you have almost complete loss of the central vision.
But he will not benefit of the neurosensory detachment will not go again with injection.
I'll give him the benefit of the doubt and give him probably 1 or 2 injections, but I will not expect much improvement of the vision. Mostly on the best condition, he may go to probably counting fingers 30 centimeters or something like that, but don't expect much. And
so
in Western countries, they have a limit for the vision for which you can give injections. So they say probably if the vision is less than, if I recall correctly, 160, there's no value of giving more injections. But I need to revise that if it's 160 or less.
Okay. My question here is, so the conclusion, is it an inactive CMV or an active CMV?
I'll say it's a CMV scar with activity.
CMV scar with activity. Okay.
Okay. And again, this goes with the fluorescein. As you said, there is an area of well-defined scarring and staining with a small area of leakage there, which indicates the active area now. That's giving this subretinal fluid.
Okay. Actually, these are the other cuts with different angles. I don't know why he did these angles, but it seems like it's well circumscribed.
This indicates mostly that it was a scar. This is why it's well circumscribed, but there is an active part of this scar that is giving this leakage and causing this subretinal fluid accumulation, this neurosensory detachment.
دكتور اسلام لو سمحت،
نعم
في الصورة بتاعت الاو سي تي اللي فاتت، الويل ديفاين فايبروزس والحاجات دي كلها والسكار، ليه ما احطش في دماغي ان هي ممكن تبقى اي حاجه مالجنانسي او اي حاجه تانية وهي اللي عامله كده.
Very good question. But if you have the condition seen in both eyes and you know, there is something called common things are common. Okay, old age, both eyes are having this appearance. Clinical examination, you will find drusen. Fluorescein angiogram showing this well circumscribed area that goes with the scar. I'll consider it an a CMV scar. But of course, one of the differentials of the non-pigmented choroidal lesion is, you know, it's called amelanotic melanoma, choroidal metastasis, choroidal osteoma, and CMV scar. It goes in the differential diagnosis. So very good way of thinking from you. But you know, here I'll say that common things are common. If everything is going with age-related macular degeneration, I will put it on top of the list.
شكرا حضرتك يا دكتور.
Okay. Anyone else would like to present?
دكتور اسامه، معلش سؤال على موضوع الاستيرويدز اللي حضرتك سألته بعد
يا ريت.
كنت سمعت في توك في مؤتمر كده عن حد جايب سيرة الأوزوردكس إن هو لسه بيستخدم، وبشوف ناس كتير يعني على النت
is licensed for the intravitreal. The Ozurdex is a dexamethasone implant. It's used nowadays more than the triamcinolone because it's thought to have less side effects. So you know, sterile reaction that is common with the triamcinolone. It's common to have, you know, sterile intraocular inflammation, especially with the Kinacort that we use because it has preservative. So the Ozurdex, it gives, you know, continued release of the dexamethasone over the period of 4 to 6 months. It's licensed to be used in diabetic macular edema and in macular edema secondary to retinal vein occlusion and in
uveitis.
Yeah, exactly. Uveitic patients, posterior uveitis. The main problems that are very similar to that of the Kinacort or the triamcinolone injections: high rate of cataracts formation, high rate of steroid-induced glaucoma. Many patients may require intraocular pressure lowering drops, and few patients may even need glaucoma surgery. And the effect fades with time, so it gives good effect for 4 to 6 months, and then the effect starts to fade, and you need to do something to either repeat the injection or do something else for the patient. But it's still a very useful tool in patients who are pseudophakics and who are not responding very well to anti-VEGF injections, or sometimes the patient may don't like the idea of having repeated injections that are repeated every month or 2 months. So he or she may prefer to come once every 4 to 6 months to have the Ozurdex injection and, you know, stay stable for a bit of time. So it's still used. It's still very, very useful. But the anti-VEGFs are the main treatment right now.
شكرا
دكتور صابر. Would you like to دكتور ايمان اتفضلي. حد عايز يسأل حاجة؟
أنا مش عارفة هي الشاشة عندي صح.
تمام. we can hear you and we can see your screen.
البيشنت ده هو بيشنت كلاسيك دايبيتك ماكلر دايبيتك ماكلوباسي أو دايبيتك Proliferative diabetic patient و 34 years old. هو diabetic for 15 years old. مفيش no hypertension, no cardiac, no smoking. He receiving only insulin for controlling diabetic, no history of trauma. We had 3 intravitreal injection Lucentis cystoid macular edema من 2 years. 2 months before this visit he came with severe dropping vision. We asked to do ultrasound and OCT because we thought about the vitreous hemorrhage. He came severe blurring of vision, especially in his left eye. Examination was free except for the classic fundus finding in diabetic patient, retinal hemorrhage, exudate, microaneurysm. left eye can't be examined because of opacity, which will proved by ultrasound. We see here some vitreous opacities, and I think there is some posterior vitreous detachment, but I think the retina is intact.
You know, if I look at those scans, I'll say that the retina is intact and this is vitreous opacity. Do you know why? Why did I say this? Of course, it's an operator dependent. The ultrasound is operator dependent. But if I'm looking at one of these scans, is giving me a clue that this is a vitreous hemorrhage rather than a retina.
دكتور اسلام والاttachment عند الاوبتيك نيرف هيد.
Exactly. This is the clue that I looked for. If the retina is usually attached to the optic nerve head, while the vitreous is usually not attached to the optic nerve head. Here on the lower left hand corner, you can see that the hyper-echogenic structure is not attached to the optic nerve head. Okay? So I'd say mostly this is a vitreous hemorrhage rather than a retinal detachment.
Okay. There is no for ultrasound.
Sorry?
حضرتك عايز أعلق على أي حاجة تاني دكتور في الالتراساوند؟
لا تمام. I'm okay. Anyone would like to ask anything about the ultrasound?
تمام. هي فلورسين.
معلش يا دكتور اسلام، الجين اللي تحت ما بيديناش انديكيشن اذا كان هيموريج ولا ريتنال ديتاتشمنت.
Of course. هو في factors، في كذا حاجة بتفرق لنا هل هي there are many factors that we use in the ultrasound to differentiate if it's just a vitreous detachment or a vitreous hemorrhage, or if there is associated retinal attachment. This is the 1 million pound question that we are always looking for answer by the ultrasound. So one of them is the attachment of the membrane to the optic nerve head. If it's attached, it's retina. If it's not, it's vitreous. Second thing, that the vitreous usually will disappear on lowering the gain. So if you will decrease the gain to something like 60 decibel, usually it disappears, while the retina will remains visible. The third thing is the A vector. So if you look at the A vector below the B scan, can you see it? Usually there is a high reflectivity of the retina, almost equal to the reflectivity of the sclera. While with the vitreous, usually the reflectivity is low, like this patient, for example. And the final thing is called the kinetic examination. So while having the probe over the patient's eye, ask the patient to look to the right and to the left. If it's vitreous, you'll find that the hyper-echogenic structure is moving excessively. If it's retina, usually the retina is stiff, so it will not have this kinetic mobility while looking to the right and to the left. Okay?
Okay, thank you.
Okay. طيب this is the left eye دكتورة إيمان، مش كده؟
أيوة تمام. هو محتاجش اللي هو
طيب.
يعمل كان كومبلين من الليفت بس.
تمام. طيب هو هنا السؤال، احنا ليه عملنا الترا ساوند اذا كان الفلوريسين قاري واذا كان كلينيكالي انا قادر اشوف؟
لا هو ده الليفت اي ما كانش ما قدرناش نشوف الفندس فيها. الرايت هي اللي كان اكزامنت. بس الليفت
Show me the next slide, please. No, the next, not the previous.
Oh, sorry.
This is the left eye.
Mm.
It's visible by the scan.
يعني حضرتك شايف إن ما كانش فيه داعي للألترا ساوند؟
هو النقطة بالظبط احنا دايما we should you know request the ultrasound if the retina cannot be seen clinically. If, for example, there is an inferior retinal hemorrhage and I'm not sure if the retina is attached or detached underneath this hemorrhage, I may request the ultrasound. But if I can see the retina, there's no need for the ultrasound. It will not add additional value, if you know what I mean. So from just this scan, I can say that the patient is mostly having lots of retinal hemorrhages at the upper superior to the macula and a boat-shaped retinal hemorrhage at the lower part of the macula. And if we'll move to the next slide, please. As you can see, the fluorescein is seen. It's very clear here. So despite the vitreous hemorrhage, we can still see, we can still have a look. So I would save the patient the money of the ultrasound. There's no absolute need for that. This is something you should consider in your practice in the future, okay?
هو كان مش احنا اللي طلبنا الالتراساوند، هو كان جاي عاملها، هو كان جاي بعد الفيترس.
جاي عامله. Okay. I'm just trying.
أصلا.
I completely agree with you. There's no problem. I'm just trying to you know, we are trying to improve our way of practice, okay?
Okay.
So if you will comment on this fluorescein, what will you say?
I will see. There is, I can't see micro. I think it is something macro aneurysm and the leakage on from the capillaries. And I think here there is some area of capillary dropout. And Fovea, avascular soon, I can't clear it well. It is distorted something. And I
what
think
about those areas of hyperfluorescence that are scattered all over the fundus?
Yes.
Different. What do you think those are?
NVEs.
NVEs. And again, if you look just underneath the disc in the right lower photo, if you compare that to the photo above it, you'll find that below the disc at probably 5 o'clock position and 7 o'clock position, there are two areas of hyperfluorescence. Can you see them?
You can't pointing.
Unfortunately, no problem. But if you focus on the late angiogram, look at the disc and look at 4 o'clock position and 6 and 7 o'clock position, or 5 o'clock position and 7 o'clock position. You'll find that there are two like horns of hyperfluorescence.
Yes.
Those indicates that there is, in addition to the NVEs, there are some NVDs.
Yes. Yes.
Okay. So the conclusion that this patient is having what?
Proliferative diabetic retinopathy.
I'll say it's high-risk proliferative diabetic retinopathy. Does anyone knows when we say high-risk proliferative diabetic retinopathy?
لو في NVEs about 1/3 of the disc أو NVEs with vitreous hemorrhage yes أو NVDs with vitreous hemorrhage.
Exactly. So we should have 3 or 4 presence of the new vessels, location of the new vessels if they are on the disc, extent of the new vessels if the new vessels of the disc are more than 1/3, if I recall correctly, of the disc area, or NVEs more than 1/2 of the disc area, and presence of vitreous hemorrhage. If you have any 3 of those 4, you should consider as high risk PDR. Okay. What else did this patient have? What other scans?
الOD هي يعتبر proliferative بس there is no complication not high risk as others.
let's have a look on the fluorescein. Okay, so again, the extent here is big. So we have presence, location at the disc, extent is big. Even though it hasn't bled yet, I'll still consider it as high risk proliferative diabetic retinopathy.
But there is no OVDs.
Sorry?
There
no
is no
MVDs.
NVDs.
The MVDs, by definition, the MVDs are any neovascular tuft that is present on the disc
around
or
the
in
disc.
the area of the retina, one disc diameter around the disc. So here, I'll say that the superior nasal tuft is within this one disc diameter area. So I'll consider it as an NVD.
Okay.
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 And what about the fovea here in the fluorescein?
Yes, I want to ask about the fovea. There is lesion, but it's decreasing in the late phase.
Yeah. What do you think about the fovea, Dr. Iman?
I think there is some hyper هي الفاس not rounded. I think there is some ischemia and maybe some edema of the macula.
But in addition to the FAS, I'll comment on two things. First of them, there are many microaneurysms in the macular area, and mostly those microaneurysms will be leaking. So I'll expect that there is some leakage maculopathy in the OCT. That's the first thing. Secondly, inferior temporal to the foveal center, there is a hyperreflective or a hyperfluorescent lesion that is more or less looking the same to me throughout the angiogram. So I'll say mostly it's hard exudate. But if we look at the OCT, it will either confirm my diagnosis or make me change my mind. So here there are some microaneurysms, and there is like a hyperfluorescent lesion corresponding to probably hard exudate.
You mean besides the face?
Just inferior temporal to the FAS, yes.
You can move or okay. دي برضو another photo في الأودي.
Okay. As you can see, there are extensive vascularization elsewhere.
Yes.
Okay.
Doctor, the hypofluorescent area in the lower two, they are capillary dropout or hemorrhage?
No, mostly capillary dropout. Usually, the capillary dropout, the hemorrhage will appear like filaments covering the retina or areas covering the retina. But the capillary dropout, you will be able to see the large retinal vessels, but the capillaries in between them, they are not giving the grayish hue.
طب وده ليه significance عندنا يا دكتور؟ يعني ده هيفرق في حاجة مثلا؟
يس، ان هو ساعات لو العيان ده ابتدى يدخل في هيموريدج، فلو الهيموريدج ده مثلا جاي بريماكيولار هيموريدج هيحتاج فيتراكتومي، لكن لو هو just capillary drop out it can be treated with laser.
تمام. شكرا. اوكي.
تمام.
هو التريتمنت هو كان بارس بلانا فيتراكتومي for the left. وقامت الرايت هي asked to do OCT.
Okay.
There is OCT بس I don't know here. Okay, I will search. مش عارفة هو ده مميز.
Okay. So you have the OCT of both eyes, the right and the left.
I don't know. Is a patient or another patient? لا, it's not a patient. I don't know where the CT. Sorry about that.
Okay, that's fine. So the important thing here that this patient needs urgent PRP for the right eye. And again, for the left eye, if I were the treating doctor, and if there is
I think the OCT of the OD.
Okay. So as I said, there is some intraretinal fluid. indicating leakage mostly related to the microaneurysms that I showed you on the fluorescein. Okay, so
Okay.
if I were the treating doctor, what would you do for the right eye of this patient?
He was planning for injection, but we asked him for OCT for the left eye, to decide for barzolvolepharoptomy or injection.
Okay. No, I'm talking here about the right eye. If you have the fluorescein and the OCT of this right eye,
I think he
has
needs
iris PDR and cystoid macular edema in the fovea, what would you do?
I think he need more injection. هي مشكلته بس اللي هو كان بيتحاسب
I would do PRP as soon as possible دكتور اسلام، لان هو في هاي ريسك انه يحصل له hemorrhage وما يبقاش في فيو اعمل منه PRP.
Okay, let me tell you something. If I were the treating doctor of this particular patient, I would go for one injection first, followed by PRP. Why? Because if you will do PRP straight away, there is a very high chance that even without any complication of the PRP, the patient will bleed and the patient will develop vitreous hemorrhage. Just when you do the laser treatment, when the vitreous starts to contract, it will exert some traction on the NVDs and the NVEs, and this may lead to some vitreous hemorrhage. And at that stage, the laser will be blamed that it caused the hemorrhage. If you'll do injection, usually it causes some regression of the NVDs and the NVEs and decreases the probability of developing such bleed. The main problem with the injections that their action is not finite. They remain for 3 to 4 weeks and then the activity starts to appear again. So this is why in high-risk proliferative diabetic retinopathy, many practitioners will think about giving a single injection first, followed by laser treatment. Okay?
Okay.
And you will hit two birds with one stone. It will help to treat this cystoid macular edema and decrease the proliferative complications as well.
دكتور دي نقدر نقول عليها cystoid macular edema ولا؟
Sorry, the cystoid macular edema, yes. Yes, this is a cystoid macular edema, yes.
Okay.
But it's not marked, it's mild cystoid macular edema.
Dr. Islam, would you go for vitrectomy for the left eye?
Actually not, unless there is a significant traction on the OCT or fibrovascular growth causing traction, threatening or involving the macula. But with such mild bleeding, I would go for staged PRP, so doing some PRP and waiting for some time, giving some time for the bleeding to resolve, and then doing the second session, etc., etc. It may work in some patients. In some patients, if the bleeding is persistent, then I'll do PRP afterwards.
هو بس يا دكتور كومنت، هو كان جاي بعدها بوقت، فكان الفيترس يوم ما احنا كنا بنشوفه ما كانش باين خالص، يعني هو كان الهيموريجي كان زيه.
Okay, but it's still with, if it's not, there are some clear indications of vitrectomy in diabetic patients, including non-clearing or recurrent vitreous hemorrhage, including premacular hemorrhage, subhyaloid hemorrhage affecting the macula, including tractional retinal attachment threatening or involving the macula, including progressive fibrovascular growth despite maximum laser treatment. I don't find any of these indications in this particular patient. The only cause that I may consider vitrectomy for, if there is a significant macular traction that requires vitrectomy. But with the fluorescein scans that you showed, the hemorrhage was not that bad. Okay, so you could save vitrectomy is not an easy surgery. You could save the patient this surgery and do him laser treatment, or at least try to do that. It may work or not, but not to go for the vitrectomy from the beginning.
دكتور اسلام بعد اذن حضرتك، انا بس مش فاهمه كويس الكالر ماب اللي فوق الاو سي تي، مش فاهمه الاكسبلانيشن بتاعه.
الكالر ماب دي اتس ا فولس كالر ماب، تمام؟ يعني احنا الاو سي تي بياخد الصوره بتاعت الماكيلا، وبعدين شفتي خرائط التوبوغرافيا بتاعت the topography maps اللي بيستعملوها مثلا الناس بتوع الجيوغرافي او الميليتري ساينسز، ان هو يقول لك the summit of the mountain appears red because it's very elevated from the sea surface, while the sea surface appears blue because it's not elevated. If you look just next to this color map there is a scale. السكيل ده نبتدي من اول اللون البلاك خالص and on top of the scale it's white. The cold colors are at the bottom, the hot colors are at the middle or at the top. So what the machine does is to put a color code for the thickness of each area of the macula. This will help you to draw the thickness in your mind. So for example, at the center there is the green color of the foveal pit. Then around it there is the yellow orange color of the slight thickening of the area around the fovea. Inferotemporally at the area of probably 8 o'clock and 9 o'clock there is a thickened area of the retina. Okay, so this is the only advantage of this color coded map is to give you an indication where the thickness is. Okay.
اوكي دكتور، شكرا لحضرتك.
امر دكتوره ولاء. ها اسئله تانية؟ سهرناكم وتعبناكم، اقول عليه بس يا رب تكونوا استفدتوا. Do you think that we need to arrange another meeting for the others to present, or the others don't like to present? You know, you have the marks of the assignment. I'll give you all the marks of the assignment by just sending me the cases on the mail. But I wonder if the others would like to present or not. This silence means probably not, isn't it?
We want.
Sorry?
We want, doctor.
You want to present? Okay. So probably we can arrange another appointment, probably next week, and so that the others who want to present, they are more than welcome.
Thank you very much.
If you have any questions, just prepare them. Usually it's good to have this kind of discussion. It opens, our minds about things. Okay?
Yes.
Okay. All the best. Take care. Sorry for keeping you awake that late, and all the best. Okay?
شكرا دكتور اسلام.
Thank you دكتور اسلام.
تصبحوا على خير. سهرتكم حقكم عليا. باي باي.